Welcome to MED-MYSTIFY. Today, we're diving into an explainer that completely breaks down the dense pharmacology of congestive heart failure. We're going to turn all that complex information into a highly organized, totally logical framework. So if you've ever felt completely overwhelmed by the sheer number of cardiac meds and their crazy molecular targets, well, you're in the exact right place. We're going to make this crystal clear.
Okay, let's dive right in. I want you to think of the heart not just as a biological organ, but really like a struggling mechanical engine. You see, when a pump starts to fail, you can't just expect it to magically work better on its own, right? You need specific, targeted tools to either force it to work harder or you got to make it carry a much lighter load. And honestly, that's exactly what our pharmacological toolkit does when it comes to congestive heart failure. Here is our roadmap for this explainer. 1. Boosting output. 2. Clearing fluid. 3. Blocking RAAS. 4. Calming and offloading. And 5. The ultimate memory trick.
Section 1. Boosting output. Positive inotropes.
So positive inotropes are pharmacological tools for directly increasing the force of myocardial contraction. We're essentially giving the engine a temporary jump start to get that cardiac output up. Now, with a classic cardiac glycoside like Digoxin, we see this absolutely fascinating cellular domino effect. It kicks off by inhibiting the sodium-potassium ATPase pump right on the cardiac myocyte membrane. What happens next? Well, that causes a backup of intracellular sodium, which in turn seriously slows down the sodium-calcium exchanger. And since less calcium is being pushed out of the cell, the intracellular calcium just spikes. It's simple. More calcium stored in the sarcoplasmic reticulum means a much stronger force of contraction during systole. Plus, digoxin has this really cool neurohormonal effect where it increases vagal activity. That actually lowers the heart rate and AV conduction, while at the exact same time, it's boosting that cardiac output. Talk about a multitasker.
Now, let's contrast a couple of other output boosters. On the one hand, we've got dobutamine. This acts as a straightforward beta-1 agonist, directly stimulating those receptors to bump up cyclic AMP, intracellular calcium, and boom, contractility. But on the flip side, check out Milrinone. By inhibiting phosphodiesterase puri, it actively prevents the breakdown of cyclic AMP. In the heart muscle, sure, this boosts contractility. But in the vascular smooth muscle, this exact same process actually decreases intracellular calcium, causing things to relax. So Milrinone is kind of amazing because it gives us a 2-for-1 deal. Inotropy plus vasodilation. It drops both preload and afterload all at once.
Moving right along to Section 2. Clearing fluid. Diuretics.
Let's see how making the pump's job easier by getting rid of excess fluid really builds on our overall strategy. Listen, if we can't just flog the heart indefinitely, we have got to lighten its cargo. And we've got 3 different approaches to diuresis here. Thiazides handle your mild fluid retention by blocking the sodium chloride cotransporter in the early distal tubule. Furosemide, that's your loop diuretic for the heavy lifting and powerful diuresis. But you really need to look at spironolactone. The crucial point here is that while all of these drugs reduce blood volume and preload, spironolactone is completely unique. Because it's an aldosterone antagonist, it isn't just dumping fluid. It actually prevents dangerous vascular and cardiac remodeling, not to mention myocardial fibrosis. It literally acts as a structural shield for a failing heart.
Now, if a patient is severely congested, furosemide is the absolute heavy hitter you need. It follows a distinct set of steps to rapidly drop preload. By inhibiting the NKCC2 cotransporter in the thick ascending loop of Henle, it aggressively ramps up the excretion of sodium and water. This drops the extracellular fluid volume and venous return, which is exactly how you resolve life-threatening issues like pulmonary edema. Oh, and here's a bonus. It causes a relatively rapid venodilation, which starts dropping that preload even before the full diuretic effect fully kicks in.
All right, Section 3, blocking RAAS, ACE inhibitors and ARBs. Now we're looking at blocking the harmful neurohormonal activation of the renin-angiotensin-aldosterone system, or as we usually call it, the RAAS pathway. This is a classic pharmacological showdown. Both of these sibling drug classes are incredibly successful at reducing afterload, preload, and adverse remodeling by just shutting down the effects of angiotensin II. But ACE inhibitors like enalapril or lisinopril, they stop its creation entirely. And that has a fascinating secondary effect. It decreases the breakdown of bradykinin, which actually leads to even more vasodilation. On the other hand, an ARB like Losartan takes a different route. It directly blocks the AT1 receptors to prevent vasoconstriction and aldosterone secretion, but it does absolutely nothing to bradykinin levels.
On to Section 4, calming and offloading, beta blockers and vasodilators.
Our fourth set of tools is all about intentionally slowing the heart down and widening the pipes to drastically reduce the overall cardiac workload. Now, I know what you're thinking. It might seem completely counterintuitive to use beta blockers when a pump is already failing, right? Especially since their short-term effect actually acutely reduces cardiac contractility. But here's the secret. Long-term controlled blockade actually protects the heart. By shutting down chronic sympathetic overdrive using selective drugs like Bisoprolol or Metoprolol or the multi-receptor blocking Carvedilol, we decrease catecholamine toxicity, we prevent deadly arrhythmias, and we put a stop to adverse ventricular remodeling. Essentially, we're forcing the engine to pace itself so it can survive for the long haul.
Looking at our pure vasodilators, we see this brilliant division of labor. On one side, we have nitrates, like nitroglycerin, which release nitric oxide to heavily dilate the veins. This drastically drops preload, meaning way less blood is dumping into the heart all at once. Then, on the other side, we've got hydralazine. This one specifically targets the arteriolar smooth muscle, dropping systemic vascular resistance to heavily reduce afterload.
So what happens when you put these two together? Well, you essentially widen both the entrance and the exit pipes. Combining hydralazine and nitrates perfectly complements both mechanisms. Reduced preload plus reduced afterload equals a dramatically reduced cardiac workload. You're basically pushing forward cardiac output without forcing the heart muscle itself to work even a tiny bit harder.
And finally, Section 5, the ultimate memory trick, putting it all together.
Let's synthesize all of this incredibly complex pharmacology into a super memorable framework that you can easily recall for exams or, your future clinical practice. This high-yield summary shows exactly how each major drug class interfaces with its primary cellular target to fix that failing pump. We've got Digoxin targeting the sodium-potassium ATPase pump, Milrinone going after PDE3, and Furosemide, that's blocking the NKCC2 transporter. Meanwhile, ACE inhibitors are shutting down angiotensin II, Carvedilol is blocking those sympathetic receptors, and nitrates are using nitric oxide to open up the veins. It really is an absolute masterclass in targeted molecular therapy.
If you can just remember this one brilliant line, you can mentally reconstruct the entire pharmacological treatment protocol for congestive heart failure. Ready? Increase output, remove fluid, block RAAS, calm the sympathetic system, and reduce vascular load. Seriously, that single sentence contains literally all the categories we just discussed. It gives you the perfect mental anchor for the whole shebang.
So, I'm going to leave you with this provocative thought. By treating the immediate symptoms of fluid overload, how are we also stopping the long-term structural progression of heart failure? Think about it, how symptom relief and long-term cardiac remodeling are just so deeply intertwined in these therapies. When we drop preload or block aldosterone, we aren't just making the pump run smoother today, we are structurally protecting it for years to come. Thank you so much for joining me today on MED-MYSTIFY. Please like, subscribe, and share this with your friends for such more pharmacy-related informative explainers. Be sure to write your queries in the comments section. Catch you next time.